So we will, as those folks who attend work group or stakeholder meetings for the MIA know, we usually record and then we will put that on our website so that it's available for anyone who was unable to attend or who couldn't take notes fast enough. So good morning, everyone, and welcome to the first public stakeholder meeting hosted by in response to House Bill 413's interagency work group. My name is Kathleen Bahrain, and I serve as the Maryland Insurance Commissioner. So as most of you joining us today are aware, in 2022, the Maryland General Assembly passed House Bill 413, which requires the Maryland Insurance Administration, in consultation with the Maryland Health Benefit Exchange and the Maryland Healthcare Commission, to report to the governor and the General Assembly by December 1st, 2023, on the impact of the state reinsurance program. To complete this report, the MIA formed an interagency work group with representatives from the MIA, MHBE, MHCC, and the Maryland Department of Health. Representatives of these agencies have been meeting bi-weekly since February to discuss the topics required to be included in the report, which are set forth in the uncodified language of House Bill 413. And over the course of the past 3 months, this work group has considered things such as the necessary level of funding for the program, sources of funding for the program, market reforms needed to provide affordable health coverage in the individual market, the design of the program, and the program parameters in light of existing market reforms at the state and federal level. Each of those topics are topics that are included in the uncodified language that the legislature directed us to consider. The work group has examined reinsurance program performance and impact here in Maryland, as well as best practices from other states. The report that we're assembling is not intended to simply be a reflection of our agency's views of the reinsurance program and each of these topics. It is critically important to us to have feedback from stakeholders and interested members of the public to ensure that what we present to the governor and the General Assembly is an accurate, well-rounded reflection of the Maryland reinsurance program, and that the recommendations that we make are made in consideration of all of the points of view and all of the views and all of the ideas that come from our stakeholders as well as our agency representatives. So while there's little debate as to the success of Maryland's reinsurance program and its stabilization of the individual market and provision of necessary premium relief to many Marylanders, we do understand that there are components where there are disagreements and areas of disagreement. So in light of that, we appreciate all of you joining us today in order to pursue for us 3 goals. The first is to discuss the reinsurance program as it is and as it should be by identifying issues and opportunities for improvement. The second is to have a productive and constructive dialogue and conversation about the program itself and areas of debate within it. This will hopefully lead to goal 3, which is to reach reasonable consensus where we can on critical components that will inform both the actuarial and modeling, which will be presented in meeting 3, as well as the recommendations that will be made in the final report. So on the subjects where we may not reach consensus, we look forward to gathering diverse feedback to best inform our report and articulate honestly and transparently what the areas of disagreement were and their impacts and why ultimately the report may make one recommendation as opposed to the other. But we want voices to be heard. We want positions to be understood so that our report ultimately is very thorough and transparent about what all of the ideas and concepts are. So for today's meeting, our goal is to discuss Maryland's reinsurance program, design, size, and parameters, and hopefully have rich discussion on key decision points that will then inform the actuarial modeling that the working group will be producing for discussion during our 3rd meeting. So let me just start by doing 2 things. First of all, just from a kind of a housekeeping perspective, I'm going to ask people to make sure they stay on mute unless they're talking. We will have a series of we'll have a presentation by Brad Boban, who's the MIA's chief actuary, but then we will have kind of a guided discussion. We've broken the discussion into many topics, and we would invite people to who comment on those topics and give their points of view during those discussions. If there are folks who are on the line, who are attendees who did not sign up to be a panelist and to speak, but you have comments that you want to make and you want to be heard, as I always say, as time and technology allow, we will bring you over into the panelist section so that your thoughts, so that we can hear from you and get your thoughts as well. So because we'll pause after each section and give people the opportunity, and then we will have a 15-minute section at the end for folks to just be able to speak more broadly beyond the structured conversations that we have planned. So with that, and since this is really our first meeting, I'm just going to take a moment to introduce the members of the MIA team who are present today, and then I'll invite each of the other agencies that are members of the work group to introduce themselves and the members of their team that are here today. So let me start by introducing the MIA's chief actuary, Brad Boban. We also have, I believe, present our senior actuary, Adam Zimmerman. Our director of government relations, Andrew Tress, is on the line, and our chief of communications and public engagement, Craig I, is here. If you have questions at any time about any of these communications, you can direct your questions to Craig. We have a public website posted where all of the materials, this recording ultimately will be housed. We will invite people at the end of this hearing, if there are and the end of this meeting, if you have comments, if you have thoughts, if you have submissions that you want to make in writing to the working group, then please send them to Craig, and he will make sure A, that we get them, and B, we will also post them publicly so that everybody can see what those thoughts might be. So with that, let me note that we are also joined by representatives from the Maryland Health Benefit Exchange, and I will ask them to introduce themselves, or Michelle to introduce them.
Thank you, Commissioner Bahrain. Appreciate the opportunity to be here today. I am Michelle Eberly, the Executive Director for the Maryland Health Benefit Exchange. And with me today, I have Johanna Fabian Marks, our Director of Policy and Plan Management, and Becca Lane, who's our Senior Health Policy Analyst, who have been working tirelessly on the 1332 waiver for many years, and we're looking forward to the next iteration.
Thank you. And next, I'll ask representatives of the Maryland Healthcare Commission to introduce themselves.
Thank you, Commissioner. This is Ben Steffen. I'm the Executive Director of MHCC, and with me is Ken Yates-Trotman, who is the Director for our Analysis and Information Systems Group, as well as I think we have online is Tracy DeShields, who many of you know, who's Director for Policy Development and External Affairs. Happy to be here, and I look forward for comments from the stakeholders as we move forward to the next stage on reinsurance.
Thank you. And we are also joined by representatives of the Maryland Department of Health, who I'll ask to introduce themselves now. I don't know who wants to take the lead. Marie?
Thanks, Kathleen. Hi, everyone. Marie Grant, Assistant Secretary for Health Policy at the Maryland Department of Health, and I'll turn it to my colleague, Alyssa.
Good morning, everyone. Pleasure to join you. My name is Alyssa Brown. I'm Director of Innovation, Research, and Development for the Medicaid program. Looking forward to the discussions.
That is great. So I'm going to now turn the meeting over to Brad Boban, who will start with sort of an overview of the action plan and schedule for the work group, including opportunities for stakeholder engagement. And then Brad will take us through our first agenda item. So Brad, the floor is yours.
Thank you, Commissioner. Yeah, I mean, briefly to start off with, as far as the action plan goes, as the commissioner outlined earlier, this session is going to focus mainly on the reinsurance program itself, the performance of the reinsurance program to date, the comparison with other states, and discussions about what changes we might want to make to the reinsurance program. Then session number 2 is going to focus on other market reforms that could be used in concert with a reinsurance program. 2 of the ones that we're going to discuss are premium tax credits and cost share subsidies. But we're also going to discuss other market reforms, and the details of all of those. And so then from the feedback from the first 2 sessions, we're going to do the actuarial modeling. And just to be clear, there's going to be feedback, after I go through my slides, there's going to be opportunity for in-depth discussion on all these points, and I will welcome everybody to please chime in and voice your opinion, live on this meeting. But we will also be accepting written comment as well. So if you want to take some more time to digest the numbers that we're putting in these slideshows, to put together a more thoughtful response, we will also be taking written comments on these. But based on the feedback from the first 2 sessions, we're going to do actuarial modeling. Part of the reason why we're going to do it that way is because these programs are all interrelated. If we pursue a premium tax subsidy, it's going to influence the reinsurance modeling. It might influence it positively or negatively. That would have to be modeled out, but it's definitely going to have an impact. There's going to be more people getting reinsurance, more pass-throughs being generated, and the interactions need to be modeled out. So then the third meeting is going to be going through the model results. We're going to be modeling a range of scenarios. We're not looking for one single point estimate. We're looking at a range of reasonable size reinsurance programs, reasonable subsidy programs, and at that point we're going to focus on the funding and how the funding can be raised and what funding level is needed for different combinations of these programs. So I think with that, Craig, if you could tee up the slideshow.
Yes, let me get that ready. Okay, are you seeing the opening screen?
Yes, and if you could go, I think 2 slides in. Yeah, thank you. All right, so at a high level, reinsurance is a program that has been pursued by 15 states via a 1332 waiver. It is modeled after the federal transitional reinsurance program that ran from 2014 to 2017. It was one of the 3 R's when the ACA was initially launched: risk adjustment, reinsurance, and risk corridors. It functions by reducing premiums in the individual market by covering a portion of the claims for the highest cost members. And so the reinsurance program is funded by a combination of state funds and federal pass-throughs. And federal pass-throughs are generated by saving the federal government money. And this works because the premium tax credits that members receive when they are of an eligible income on the exchange, the amount of premium tax credit depends on the unsubsidized premium for the benchmark plan, for the second lowest cost silver plan. So reinsurance lowers that unsubsidized premium for the benchmark plan. And by doing that, that lowers the amount of subsidy that the federal government has to pay. And they are passing through all of that savings to the state to run their programs. Reinsurance is an initiative that can only be pursued via a 1332 waiver. Without a waiver, carriers would not be able to remove those claims from the rates because the ACA rating provisions are very strict. And so only states that are doing this are doing it via a 1332 waiver. Next slide, please, Craig. So Maryland's waiver was approved in the summer of 2018 for a 5-year period from 2019 through 2023. We weren't the very first one. There were 2 reinsurance waivers the year ahead of us, but we were near the beginning of the wave of these waivers. We recently, as a state, submitted an extension for our waiver for 2024 through 2028. That's currently under review by CMS. We've gotten confirmation that everything is complete, and the federal public comment period for that is underway. The state part of the funding was originally a one-time, 1-year, 2.75% assessment on fully insured health insurance premiums in 2019. That assessment was set at a level to replace the aggregate amount of the federal health insurer fee that was suspended for that year. So the ACA had originally had a federal health insurer fee, and it ran from 2014 through 2020 with various suspensions and moratoriums. And so we used that moratorium as an opportunity to generate state funding in a premium neutral way, because the federal assessment was going away. We replaced it with an equivalent one. And so that was the original funding source. And then the year after that, a 1% assessment was established. And originally that was established through 2023, and then that has now been extended through 2028. Next slide, please. So reinsurance is a market level adjustment. So what I mean by the market, from my perspective as the actuary reviewing the individual market, you have on and off exchange, but they form one single risk pool, and all of the experience from all the members on and off exchange have to be combined, and all the plans have to be rated identically, and the same plan has to have the same rate on and off exchange. And every plan that's on exchange is available off exchange. There are some unique off exchange only plans on the silver metal level. But in general, reinsurance has to be applied equally across all of these. So a carrier can apply reinsurance differently on versus off exchange. They can apply it differently by metal level. Each carrier applies one carrier level market factor to lower the premiums. As far as how the market divides, we've got 56% of the market is buying on exchange and receiving APTCs, advanced premium tax credits. For these members, the majority of their premiums are being paid for by the federal government right now via the subsidies. And so these are the ones who, the unsubsidized premium reduction doesn't really benefit them directly. They are the ones who are generating the pass-throughs to fund the program. But then you have 29% who are purchasing directly from the carriers, and 15% who are purchasing on the exchange, but are not receiving APTC. And that 44% combined, they're paying full price. And those are the ones who are directly benefiting from the lower reinsurance premiums. Next slide, please, Craig. So this is a history of rate changes in the ACA. So, early in the ACA, we started seeing significant double-digit increases that were accelerating. And we were entering a spiral of, each year saw double-digit enrollment losses, which led to a sicker population left behind, which led to higher increases, and the market was starting to spiral out of control. And so had we not had reinsurance, in 2018, we approved a 28%. What was filed for 2019, was well into the 30s, and things would have kept on getting worse. But instead, we implemented reinsurance, and we saw 3 years in a row of double-digit increases. And at its most, rates had fallen more than 35%. The last couple years, we've seen single-digit increases, in line with trend, and overall, we still have rates that are 25% lower than they were in 2018. Next slide, please. So this shows Maryland premiums versus US premiums by metal level. US average premiums, there's not one US premium. It shows, for all metal levels, bronze, silver, and gold, the market decline that Maryland has seen over the past 5 years, and shows that, we started off, a little bit below the national average, but we've pushed significantly below the national average. Next slide, please. So I wanted to zoom in on this a little more, and I apologize if you can't read all of these premium numbers, but that top gray line, that is the US average premium. I'm now focused on the gold metal level. That's the most popular metal level for people that pay full price. 50% of members that don't get subsidies buy gold. So the gray line on top is the US national average. The blue line is Maryland, and the red line is the second cheapest state in the country. And so I wanted to bring this out. The Maryland isn't just well below average, but we are now literally the cheapest gold premium in the country. And so, back in 2018, before reinsurance, our gold premium was $456. That was below the US average, but well above the low end of states. But you've seen us falling significantly, while other states on the low end, haven't risen drastically, but also have not fallen like we have. And now in the last couple of years, our 323 for 2023 is the absolute lowest gold premium in the country, and it's 9% lower than the second cheapest state in the country. Next slide, please. This is a similar thing for bronze. I've left out the average line on this one. This just focuses on Maryland versus the second lowest, and shows the same thing that, after the first 3 years of reinsurance, it's pushed our bronze rates down to literally the lowest in the country. Once again, we're about 9% lower than the second cheapest state at this point in 2023. Next slide, please. And this shows silver. It's a similar picture. This one, Maryland is not quite the cheapest silver plan. We're the third cheapest silver plan. But I'll caveat that with these are on exchange rates. all of these numbers have come from the Kaiser Family Foundation organization, and they pull these numbers from the federal exchange and state marketplace websites. And so silver numbers for on exchange reflect CSR loads. So back in 2018, when the feds defunded CSRs, we need to let carriers recoup that money and load CSRs into silver plans. And you know, the majority of states have done that, but that makes on exchange silver comparisons less apples to apples, because to the extent that two states have different distributions of lower income individuals, that CSR load can look very different. So, you know, I would say I put more stake in the bronze and gold. And if we had the off exchange silver numbers, which we don't, I think we would have a similar picture where we were the absolute cheapest off exchange silver. Next slide, please, Craig. So this slide just shows a summer of enrollment. It's difficult to see how bad it is because of the scale of this graph, but you know, the dip that happens at the left of the graph, you know, you start off at over 250,000 back in 2016, and the market dips down to, you know, 185,000 or so in 2018. That big decline is what really drove a lot of the morbidity increases in the market, and what we were trying to reverse. And you know, you can see that it has bounced back, not all the way as of 2022. 2023 might be the year we finally get back to where we were in 2016 enrollment wise, but we've gotten a lot of the way there. And you know, and this graph also shows, you know, that the majority of enrollment is on exchange, and you know, that's become even more of a majority over time, but part of that is driven by people buying on exchange even when they're not eligible for subsidies, you know, which is perfectly fine to do. It's a comparison website, but so you know, there's some shift in behavior there. Next slide, please. All right, this graph has a lot of information in it. It's very dense. This is a graphical summary of the financial state of the reinsurance program. I'm going to start with the red line. So the red line is the cost of the reinsurance program itself. In 2019, that red line started off at a little over $350 million. And, you know, this is a projection through 2028. It has it going up to $700 million a year by 2028. Whether, you know, right now, we've only got actuals for 2019 through 2021. 2022 actuals will be available soon in the next month or so. It looks like they might come in slightly lower than this current projection, and that might shift the whole red line down slightly. But you know, in general, this is the kind of trend that you see in the reinsurance costs. Then you have the funding. There's two sources of funding in each year: the state funding and the federal funding. The state funding is the blue line on the bottom. In year one, it's a big line because it was 2.75% that year, but then it dropped to 1% for all years after that. So that is what caused that pattern. The green bars are the federal pass-through funding. There is a lot of volatility with those pass-through funds. You know, there are some years where it has dropped and then goes up in the following year. You can see in 2022, you know, the green line is pretty small compared to 2021. And you know, the final line to focus on is the black line, the fund balance. And so the first 3 years of the program, we were in a unique situation that our program was 100% funded by the federal pass-throughs, that the red line, the reinsurance cost, that green bar alone covered it. And so for 2019 through 2021, we didn't have to spend a single dollar of the state funds that we accumulated, and all of it was covered by pass-throughs. 2022, that is not the case. And so for 2022, we are having approximately 2/3 of the reinsurance costs covered by federal pass-throughs. We do have the benefit of the excess pass-throughs from the first 3 years. So that covers another about 15% or so of it. But the state is going to have to cover about 15 or 20% of the reinsurance costs for 2022. And then for all years going forward, we expect to be paying a portion of the cost. There was a reason why things changed, why we were over 100% funded. It was a quirk with how that benchmark plan for subsidies is set, that the benchmark plan is supposed to be the second lowest cost silver plan, which is supposed to be a below average cost plan. But in a majority of counties in Maryland from 2018 through 2020, only one carrier was selling policies, Care First, and they only had 2 silver plans, a HMO that was average cost and a PPO, which was far above average cost. And that PPO being the second lowest cost silver plan, even though it was a very expensive plan, drastically inflated the amount of pass-throughs. And so that situation changed when United entered the market in 2021, and is not expected to reoccur. We have no expectation that the carriers will be exiting the market, and so we're not going to look a gift horse in the mouth, but we're not going to get years like that again where we're going to be 100% funded. All right, Craig, next slide, please. This is a snapshot of 2021 uninsured data by age and FPL. For each of these categories, I've bolded the 400% plus FPL. That is the range of people that are generally earning too much for subsidies and are paying full price and benefiting from the reinsurance. You can see that for all age brackets, the uninsured rate for that higher income is pretty low. That in general, the data is showing that there is a high correlation with income and uninsurance rate, and that the lower incomes have the higher uninsured rates. As context, the state average by this metrics is 6.9%. And so 400% FPL plus for all of these age brackets is below the state average uninsured rate. So I think this is another data point to show that the group of people that reinsurance is intended to be reaching, it seems to be effective. Next slide, please, Craig. All right, and one more slide, please. All right, so now I'm going to shift to talking more about broad considerations when designing a state reinsurance program. So 14 out of the 15 states that have reinsurance are using a claims cost-based reinsurance program. And so that means the reinsurance program is, being directly modeled after the federal transitional reinsurance program. it is being dependent on a member's claims for the entire year. So it's not just looking at one claim, it's looking at the sum of all claims for a year. And it's applying 3 program parameters to each member's annual claims. It's setting an attachment point, and that is where the reinsurance kicks in. So the Maryland attachment point started out at $20,000 when we created our reinsurance program. And as you'll see in a few slides, that's lowest in the country. That's, the point at where the state starts paying. Then you have a cap, and that is, when the state stops paying, and you have a co-insurance. And, the reinsurance is going to reimburse a percentage of claims between the attachment point and the cap. And so the Maryland cap is $250,000. The Maryland attachment point is $20,000, and the Maryland co-insurance is 80%. So, the state will pay 80% of claims between those 2 ranges. For anybody that goes over that cap, the carrier is responsible for all of the claims over the cap. Next slide, please. So one state, Alaska, is running the other type of reinsurance program, which is a conditions-based program. Under this type of program, instead of looking at a claimant's annual claims and only reinsuring a portion of it, this instead identifies a list of conditions, and effectively the state covers 100% of claims for anybody with one of those conditions. So Alaska has a list of 34 conditions identified. That's changed over time. But basically, behind the scenes, the carrier transfers 100% of the premium to the state, and the state pays 100% of the claims, and the carriers are allowed to set much lower premiums because they're setting premiums for claimants that don't have one of these high cost conditions. So, functionally, this is like an invisible high risk pool. All these members still think that they are part of the normal risk pool. They still have their normal insurance card. They still pay the same premium, but the state is the one that is at risk for these. And that is the real key there, that, unlike the claims-based type of reinsurance, the state is fundamentally taking on more risk with this type of program, that, to the extent that people with these 34 conditions have higher claims costs, that is coming out of state funding, and they need to come up with a way to pay for that. And there is no limit and no cutoff like there is with a claims-based approach. Next slide, please. So there is more than one way to do a claims cost approach. 10 out of the 14 programs are just plain vanilla. They vary the attachment point, co-insurance, and cap, but they all just set one set of parameters, and the calculation for each member is straightforward and simple. 2 states, Colorado and Georgia, have created programs that vary parameters by geographic region. They both have chosen to use one attachment point and one cap throughout the state, and just vary the co-insurance. They both have 3 regions, and the co-insurances vary pretty significantly between those 3 regions. The one thing that we aren't so sure about this type of approach is that, as far as we can tell, reinsurance is still a market level adjustment in these states. And so that means that, you know, while a carrier that has a disproportionate amount of business in one of the regions will, you know, have a higher coinsurance or a lower coinsurance, that it's not going to flow back to members in that region with lower or higher rates. And so to the extent that that was the intent, you know, we're not sure that it's achieving that. But to the extent that the intent was just to encourage carriers to compete in regions that are less competitive, you know, the fact that that's not a deal breaker, it just, you know, the entire pool for a carrier would still get the same average factor, and you wouldn't have it being reflected in the geo rating. And then one state, us, Maryland, uses a dampening factor on top of, you know, the basic reinsurance to account for the interaction between risk adjustment and reinsurance. And so, you know, this was discussed extensively when we first submitted our application. You know, at its most basic, you know, the concept is that there is an overpayment between the risk adjustment and the reinsurance programs, that under risk adjustment, carriers with lower risk members pay carriers with higher risk members to balance out the risk. And under reinsurance, carriers with very high risk members with high claims are getting a, you know, part of that risk paid for by the state. And if you don't make an adjustment, that there is double counting. And, you know, our studies have shown that this is definitely a real effect, and that without a dampening factor, you know, you leave those high risk members to generate an excess profit. That if you don't make a dampening adjustment and you look at those highest risk members, that the carriers can sometimes get more in risk adjustment plus reinsurance than the actual claims cost for that high risk member. So that is why we have, you know, continued to recommend using dampening factors, but no other state has chosen to do that. Part of the reason is probably because, you know, the need for the dampening factor increases as the size of your reinsurance program increases, and we have one of the larger program sizes, as you'll see in these coming slides. But you know, to date, no other state has chosen to follow us and implement a dampening factor. So, you know, right now that's just us. Next slide, please. Okay. So this compares the attachment points for all the states that are running a state reinsurance program. Maryland is in red on the left. We're at $20,000. These are 2022 attachment points because that is the report that we could get that had all of the states in it. The Maryland attachment point has come down in 2023 to $18,500. So, you know, as far as I know, no other state lowered it. So when we have the data to redo this in 2023, I think we will be the absolute lowest, but for 2022, we were still at 20,000. You can see the highest state is North Dakota at 100,000. You know, the median is, you know, right around 40,000. Then I also put a little chart in the left side of this graph that just notes, you know, the percentage of members reaching the attachment point for each of these attachment points. This is based on our estimated claims probability distribution for 2022. And, you know, at 20,000, almost 7% of members are going to reach $20,000 of claims for the year and trigger a reinsurance payment. At the opposite end of that spectrum, at 100,000, you're only talking about 1% of the members. And you know, I'll just note that, you know, this is not a linear relationship, and you know, even if we made a moderate change to the attachment point, you could reduce the number of impacted members a lot. You know, that at 40,000, doubling the attachment point from 20,000 to 40,000 lowers it from 6.9% to 3.1%. So next slide, please. This shows the cap. This is a really interesting slide to me. It has an incredible range from low to high. You know, at the high end it is $1 million. And I would say that's the highest cap a state could really use, because there is a federal component of reinsurance embedded in the risk adjustment program, and the federal government pays for claims over $1 million, so you don't want to overlap there. So you know, I think Oregon and North Dakota are at, you know, the realistic maximum, and then, you know, Rhode Island is only a $65,000 cap. Maryland's 250,000 is actually right around the median. And then next slide, please. And then this shows the coinsurance rate. On this slide, I was surprised that it went all the way up to 100%. I knew Alaska in their claims-based, I mean, conditions-based program, by its nature, paid 100%, but I didn't think any states had chosen to pay 100% of claims. But it turns out Maine has designed their program so that they do pay 100%. But we are at 80%. And you know, most states are in the 40 to 80% range. Next slide, please. Finally, this kind of shows the per member per month result of what those parameters, you know, how much reinsurance those parameters result in being paid out. And so I've added Alaska to the slide because we do have data on them, and they are by far the largest reinsurance program on a per member per month basis. You know, almost $350. Maryland is number 2, you know, $180 per member per month. And just to be clear, you know, this isn't per reinsured member, this is across all members. So, you know, we're paying reinsurance for 6 or 7% of members, but these PMPMs are how they impact rates. And you know, without the reinsurance program, there would be $181 extra of claims built into rates every month for everybody. And you know, beyond that, just wanted to point out, you know, once again, Maryland is at the top of the range of sizes. You know, we're about double the average size. You know, the average size is, you know, a little under $90 per member per month, and we're a little over $180. So we're about double the average size. Next slide, please. This shows the other side of the equation, the pass-throughs. And you know, once again, Alaska is an outlier, and they're getting the largest pass-throughs of any state. But once again, after the outlier of Alaska, Maryland is the state getting the largest pass-throughs on a per member per month basis. And Once again, you know, we're significantly higher than the other states. You know, if Alaska wasn't shifting the scale of this, you know, you would be able to tell more that you know, we are getting about 2.5 times as much pass-throughs as the average state. Next slide, please. And finally, this is the pass-through percentage. So this basically is just what percent of your reinsurance costs are covered by your federal pass-throughs. This is 2021 because this is the last year that is complete and we have data for, and Maryland is at 101%. So you know, that meant we didn't have to pay anything. The federal pass-throughs covered the whole cost. You can see that only a couple states were over 100%, that the large majority of states were in that, you know, 65 to 85% kind of range. And as I mentioned, for 2022, we are going to be down in that range. You know, it looks like we're going to be at you know, 67% or so. And going forward in our projection period for our waiver extension, you know, we are looking to be more in line with these other states as far as pass-through percentages go. All right, next slide, please. All right, thanks. All right, I'm going to walk through some premium examples now to illustrate how ARPA has really changed things up, and you know, the importance of considering that when we make all these decisions and you know, plan how to go forward. So this first slide, all of these slides, I have put together premiums based on the 2023 rate level in Baltimore metro region. And these are all premiums for the second lowest cost silver plan, for the benchmark plan in the Baltimore metro region. This first slide shows what those premiums would be if there was no reinsurance and ARPA subsidies never happened. And you know, it shows that without reinsurance, there is a big premium cliff at 401% FPL, that if you earn 400% FPL, 54,320, your premium is limited to 9.1% of your income under the original ACA, which is $413 a month. But then if you earn a few dollars more and you're at 401% FPL, then there is no subsidy available for you. And at age 45, that means you pay $558 a month, which is 12.3% of your income. But you know, at age 64, you're paying $1159 a month, and that's 25.5% of that person's income. So those unsubsidized numbers, especially for those people just, you know, a little over 400% FPL, those were the big problem that reinsurance really needed to address. So if you can go to the next slide, please. So this shows what happens when it was the original ACA subsidy and we layered on our reinsurance. And you know, reinsurance really helped things a lot. It helped things for the younger people. You can see the age 26 rate came down to 267, and that means that, you know, a lot of people that used to get subsidies for that lower age now don't even need subsidies because the unsubsidized rate is lower than the CMS would make them pay for their subsidies, so they don't even need subsidies anymore. And then for those over 400% FPL, you know, it hasn't removed the cliff altogether, but it has made it less severe and it has, you know, delayed it. Next slide, please. And this shows what happens with ARPA. And so ARPA, this is ARPA alone without our reinsurance program running. And the numbers here are really not that bad at any income level. And that's because the big change with ARPA was the removal of the cap. And so now anybody of any income can get a premium tax subsidy to the extent that they have to pay more than 8.5% of their income for that benchmark plan. And so with ARPA, you don't have that cliff anymore. And so you can see that even for age 64, this only goes up to 600% FPL, this chart, but their premium is being restricted to 8.5% of their income. And if you compare that to the previous slide, when it was just reinsurance and the original subsidies, ARPA alone is a lot better for those old people than our reinsurance is. It's more effective at targeting those cohorts. Next slide, please. So now this shows ARPA with our reinsurance program on top of it. And so, ARPA itself has mainly controlled the premiums for the older members. And once again, reinsurance now is mainly helping the younger people. Once again, by driving their premiums down below where they need to pay subsidies. Without reinsurance, everybody in that age 45 bracket would be paying 8.5% of their income. But reinsurance is able to bring that premium down to 376, and that's even less than 8.5% of their income. And then next slide, please. And then finally, this shows ARPA with the reinsurance and the current young adult subsidies. So this has not changed anything for ages 45 and ages 64, but for ages 26, it shows that the state subsidy brings the premiums down even lower. That, under ARPA, people at 150% FPL can get a free plan, but with the state young adult subsidy, people up to 200% FPL can get a $0 plan. And then, for the other higher incomes, you can see that the contribution for the lower income, lower ages is lower for each income. All right, next slide, please. All right, so that completes all the information I wanted to put out there. So at this point, I think we're ready to move on to the conversation. Commissioner, did you want me to lead this part of this, or did you want to take over?
Just very briefly, thank you, Brad. I think one of the things that was really important as we start these stakeholder meetings was to kind of level set, to really understand, the numbers about what's been happening to date, to remind everybody why this program was created in the first place. And let's really look at what the numbers tell us it's achieved. Our directive is to, of course, provide that perspective to the General Assembly in our report. But the other part of the report is, where do we go from here? And so, Brad, I think, you and Johanna, if you want to lead through these discussion topics around, where are we with respect to design. I know that the working group put together these discussion topics and these issues. And this is intended to be a discussion with everybody who's on the call. So, there are comments that, Brad and others who are, Johanna and others who are on the working group may want to make, but we very much want to hear from all of the other folks who have signed up. And if you didn't get a chance to sign up, but there's something you want to contribute to this discussion, we made these meetings long so that we really could try to hear from everybody. So, Brad, I'm happy for you to be the one to continue with this, and we will keep our eyes peeled for, hands raised, and anyone who is, didn't get a panel and just, linked into the Zoom call, so that if they want to be heard, you just put your hand up and then we'll be able to move you over. So Brad, I'm going to leave it to you to take us through.
All right, that's fine. Yeah, Craig, are you able to put those slides back up?
Matt, did you want to start with a comment before we got into the discussion?
Commissioner Rain, thanks. I was wondering if this might be an appropriate place to ask a question about the slides that Brad just did before we get into the discussion part.
Absolutely. And
Okay,
if other people have questions about the slides, I think we're happy to entertain them at this point.
okay. Brad, thank you. That was incredibly comprehensive and very granular, and I very much appreciate that. I think my question, I have lots of questions, but my main question, I think, for right now about enrollment, back to slide 11, is that does the MIA or the exchange have estimates with unwinding starting about the folks that might have not or might not be eligible for Medicaid anymore because we haven't done a redetermination in a couple of years due to COVID? And how many of those folks do we think are going to be subsidy eligible? And if we do have estimates on the amount of folks that will sort of churn over to the QHP place, what kind of impact will that have on program and program costs?
Yeah, I mean, I will say that it's definitely something that we are thinking about and incorporating into modeling. Johanna, do you recall off the top of your head what our current estimate is? I know we talked about this recently.
Yeah, so Lewis and Ellis has incorporated estimated kind of rollover enrollment from Medicaid into reinsurance in 2023 and 2024 with the unwinding. It's a really tough thing to estimate, obviously, and I think all the states are not really sure what that's going to look like. Off the top of my head, I think what we assumed is there's roughly 100,000 people in Medicaid who, as of their last reported income or over income for Medicaid, they may not still be. So that's a rough number that changes based on federal data. There was a MACPAC report. The Federal Medicare Commission found that in prior years, roughly 3 to 4% of people who left Medicaid then enrolled in a private plan, so not very high. Lewis and Ellis bumped that up a bit for us because we have a more seamless transition process than the federal government has. So I think they assumed about a 5% conversion rate. We're of course hoping that we exceed that, but that's kind of the data I have to share now.
And Johanna, I think it's just from the Medicaid's perspective, it's worthwhile to note that this is something we're monitoring closely, but we're not going to even see our first disenrollments until the end of this month. And I think we're going to have to see that play out over a few different months to get a real sense of the trends. We know also, right, that frequently when people lose coverage, they churn back in. But even for the 100,000 people that Johanna referenced, right, that's a point in time in terms of where their income was being overscaled at some point over the last 3 years. And we know, right, that the jobs and things can change over time. So I just want to emphasize, right, that that's an estimate in terms of what that churn could look like.
Yeah, as Alyssa's saying, we should have a much better projection later this year.
Delegate Collison?
Thank you, Commissioner, and Brad, I want to add my thanks. And so my first question is, these slides will be available to us, right? Okay, that's the first question. The second question, and I'm sure I need to study more to have more questions, but the first one that came to me was, so that $181 premium dollars per member per month, at first glance sounds really, kind of shocking. But how does that compare? Can you speak to how it might compare to prior to reinsurance, where we were, I don't know if I'm remembering correctly, but it seemed to me that I heard at one point that something like, half of the premium costs that per member per month was going to uncompensated care. So are we able to do that comparison, or are they too different?
You want to compare uncompensated care to the amount that we're spending on reinsurance?
The percentage of premiums per member per month was what I was looking at. Compared to reinsurance and prior to the reinsurance program. Because back in, I think it would have been like 2016, 2017, I was hearing horrific numbers, like, if I'm remembering correctly, as much as $4,000 a year of somebody's premium was going to uncompensated care. And that, was, the impact of the way the premiums worked in terms of paying without the reinsurance program. So it was after ACA came into being, and when we had those numbers going down, when we had those mass exoduses from our individual market, there was a pretty significant percentage of the premium was going towards uncompensated care, as I recall, or I could be recalling it correctly too. So.
Yeah, I would have to research that. Uncompensated care has definitely been reduced because of the ACA. I think it is difficult to quantify what percent of a fully insured premium goes to uncompensated care, but it's possible. I don't have that number though with me.
And if there's no value in it, that's fine too. But I guess what I want to be able to say, as we think about, what is going to happen with the reinsurance program, that people were already paying for this, before the reinsurance program came in. It just was, it was individual premiums that were increased by the fact that, we were paying for uncompensated care. But maybe it's not really relevant to this discussion.
Yeah, I will give it some thought. Uncompensated care definitely, it gets, your point is absolutely right. It gets built into premium, hospital rates, and everybody pays for them. I'm not sure how much it has fallen since the reinsurance program. ACA versus pre-ACA, big change in uncompensated care. I don't know that the data supports that reinsurance versus no reinsurance has had a significant impact there, but I can certainly research those numbers.
If you think it's useful. If not, that's okay too.
And I think, Brad, that HSCRC, I should say, did work with somebody to try to take a look at this in the last couple of years. So we can also reach out to them, Vice Chair Collison, and talk to them about that.
Thank you, Johanna.
I think the next hand up was Ben Steffen.
Yes, Kathleen, why don't you go to Michelle? I think she might have a point.
I think she put her hand down because Johanna made it.
Okay, all right, very good. So this is moving on to another point that I just wanted to emphasize. I certainly think the exchange and MIA know this, but the percentage of income paid for health insurance, there is enormous price sensitivity as you move down the age scale, where we might think that 7.5% of
Hey, Craig, your entire screen is showing, so you probably don't want to show us your whole email.
So yeah, the only point I was making is that among among younger folks. There are lots of initiatives contemplated across the country and initiatives here in the state that have focused on bringing the young in, because even paying 8.5% for some young folks is not viewed as a good buy. So I think the shares of income that goes to health insurance is a really meaningful number to look at, but you have to be careful because the expectation of incurring healthcare costs is varies disproportionately with age. So, the old saying that free is not cheap enough for some youngsters, I think still rings true. And the challenge, I wouldn't want to say that's a factor we don't have to consider, because keeping young people in the insurance market is critical to keeping premiums lower than they otherwise would be.
And I think that's another part of the discussion that you guys have been having, the working group has generally been having, and then will be part of these discussions in design, right? Because this is looking at the percentage of income related to premium. That's not the same thing as the percentage of income that relates to when you're using your insurance, because obviously co-pays, cost sharing is critical. So you can have even a zero premium without having, but yet still having to incur substantial out-of-pocket costs in order to deploy your insurance. And that's a completely separate, conversation that this group, is going to be talking about in terms of what the best uses of dollars. So I think that's a really good point, Ben. So are there any other questions with either the folks who are here already on the panel or maybe others that about the slides? The slides are posted on our website. We always invite people to make comments, and we know that there's going to be a lot of discussion. We have 3 current stakeholder meetings scheduled with the idea that we'll then do a draft report, bring that back out again, and then have more stakeholder discussions. But depending on where the conversation goes, that doesn't mean we can't schedule additional sessions if there are lots of questions. But if there are no more questions about Brad's presentation specifically, then I think let's move on to the discussion topics where we want to hear from everybody. And I don't see anybody, so why don't you go ahead, Brad?
All right.
Oh, I'm sorry, Allison. Did your hand go up? Yeah, you just shouted.
It did accidentally, but I didn't mean to, so.
Okay. All right. I didn't want to not give you a chance. So
Appreciate it.
go ahead, Brad.
All right, thanks. Craig, can you go back one slide? All right. So the first thing I wanted to discuss was, the basic structure and design of the program, and should we continue with our claims cost based or consider switching to conditions based like Alaska. And I say, I think that our internal consensus so far has been that switching to an Alaska approach would be risky and not necessarily be a better way to do things. And even if we wanted to make things larger, that claims cost is definitely the safer, more controllable way to do this. But I wanted to solicit feedback and see if anybody thought otherwise and thought we should seriously consider, going down an Alaska type approach of conditions based. And I'll say that, if there is interest in that, a hybrid approach is possible. Maine had a hybrid conditions claims based for a couple years. They got rid of it and switched to claims based only. But that was the first discussion topic I wanted to throw out there.
Delegate Cullison has her hand raised.
Thank you, Michelle. So I agree with you, Brad, 100%. And my concern with a conditions-based beyond the, what I think could potentially be a, more costly, is who decides what those conditions are. And it seems to me that whenever you have a list like that, you're setting yourself up for lots of different kinds of liabilities and challenges. So for me, I think the claims-based cost has been working. All the other states are doing it, except for Alaska, which is a very different economy from the rest of the country, I think. That's my sense, is that it would be the better to continue with, it would be the better way to go.
Thanks for that feedback.
And just to add to what Brad said, certainly from an administrative standpoint, claims-based program is easier to model, I think easier for the state and carriers to project. So a lot of administrative advantages to the simplicity of a claims.
And to add to that, Johanna, I'm pretty sure Alaska has to administer it themselves, right? I mean, we have CMS contracted to do the adjudication for our reinsurance program, but I don't think that they're able to do what Alaska is doing. So we would have to build out our own process and could not leverage the CMS edge data and have the process that we have right now.
Matt?
Thank you. I think I want to, if you don't mind, talk a little more general than these particular discussion topics in front of me, just because I just saw them for the first time yesterday, and I'm not sure that I've gained enough feedback. I haven't really gotten any feedback from any of our members to really talk intelligently about which way they would like to see the program go. I mean, I know that the attachment point has been a topic of conversation, and I know that there is desire to continue with the dampening factor, but I think in general, from the carrier perspective, or some of the carriers' perspective, that we think the reinsurance program is absolutely important, and we think the whole point is reducing costs of those sort of high utilizers, but we'd like to see some sort of those dollars transitioning or translating to better outcomes. And I think, we already do carrier accountability reports, and I'd like to see some sort of out of the box thinking maybe we should include some measures for incentives, sort of like a value-based approach for, you get better outcomes with the reinsurance dollars, you're going to be incentivized to do that. And I think that it's also important to keep in mind that we need to have as level a playing field between the carriers as possible, for a variety of reasons, but it's extra important in Maryland because we don't have that many carriers, and we want to attract more carriers. And I think the only way to do that is to show that it's going to be across the board, no playing favorites. And I know that's a challenge, but I know that we can do that. Maryland takes on difficult healthcare challenges altogether. I think lastly for now, and I promise to get feedback on all these particular points, is that can we think broader too? Is this the appropriate place to think broader? And why not have a discussion? Is reinsurance the best way forward, right? I know there's been a lot of discussion nationally about the fact that maybe a straight subsidy would be the appropriate way to go. Maybe we should just scrap the reinsurance program and our dollars would go further if we just get a straight subsidy to consumers. Should we continue the conversation? I've been talking about this for years. I hope we continue the conversation that maybe we should be expanding Medicaid further than the ACA in Maryland. Maybe we could increase, we could lessen churn that way. We could take the folks that are utilizing most of the dollars and put them in a risk pool that is bigger than 250,000. That's 1.7 million. All these kind of, I think, out of the box ideas in healthcare policy could lead to something that could be uniquely Maryland. And I just don't want to make sure, I want to make sure that we're not just having discussions that are based around co-insurance, an attachment point and dampening factor. I would like us to see us do something unique that could be a model for the rest of the country. And I think that's all I have for now. Thank you very much.
Well, Matt, I think that we are aligned with the idea that this report we were not directed to just do a report on the reinsurance program. We were specifically directed to look at additional market reforms, and by market reforms, that includes things like how the subsidy programs work, et cetera. So that is, my understanding is going to be the topic of our 3-hour second meeting on May 25th, is to really invite people to talk about, what the other market reforms are. So what are we currently doing? What could we be doing? And, what is the utility of reinsurance? What part of the problem does reinsurance solve? What part of the problem does it not solve? And so you have to have other solutions. And what are those other solutions? And so I think all of that is on the table for our second meeting. So, we'll be very interested in hearing everybody's views with respect to that. We'll probably have a similar kickoff on sort of what the kind of current market reforms are and what they're doing in Maryland, and some ideas from other states. But then we will definitely want to hear everybody else's points of view on what they think things should go.
Much appreciated. Thank you, Commissioner.
Allison?
Thanks, Commissioner. Speaking to the topics on this slide, I have not heard any interest from KP in moving towards a conditions-based approach, so I thought I would just put that out there. To these, Kaiser Permanente would strongly support continuing to use the dampening factor for the reasons that you've mentioned. We think from a public policy perspective, it makes a lot of sense, prevents carriers from functionally being paid twice, once under risk adjustment, once under reinsurance. And I would note that the regulations that include this factor put it within the discretion of the MIA to recommend one if the MIA determines that one is needed. So I think that further gives you all the flexibility to manage that particular parameter as appropriate. And to your point too about the size of the Maryland program being what it is, the impact that the dampening factor can have is a real one. So that's our point of view.
Thank you, Allison. Any other thoughts or comments on these topics? I mean, I think it'd be interesting to hear what people say about, sort of what Colorado is doing, with geographic regions, or, other modifications. Matt has already previewed one, the idea of having some sort of a value proposition, that a program for some sort of a neutral determiner of, outcomes. Rob?
Thank you, Commissioner. I appreciate it. I wanted to start my comments just by thanking the MIA, Brad, and you for all your work in making this program a reality, as well as Joanna and Michelle at the MHBE. I just want to be clear from the carrier perspective, right, that we Care First strongly support the program as it's been set up. We agree with what the other folks have said here in terms of a claims-based program. I think Delegate Cullison raised some really valid points in terms of concerns with a condition-based program. I think, in terms of looking at outcomes, I think it's important just to consider that the individual market has historically been, and I think continues to be, particularly now with Medicaid redeterminations, to be a sort of a transitionary market. And so to the extent that you want to look at outcomes, I think that would probably be better done on a much broader perspective, right, than just looking solely at the individual market. You would need to sort of step back, and maybe something that would be better done by the state more broadly than solely with respect to the reinsurance program. Because again, outcomes, folks in the individual market, right, they can move in and out of Medicaid, they can get a job for a period of time, hopefully for an extended period of time. And so when you solely target that into the individual market, it may not be fully representative of what the outcomes could be for those individuals, given the amount of time that they're going to be enrolled within the program, the individual market.
Thanks, Rob.
Thank you. Other comments on these discussion topics?
Brad, can you may have done this and I might have missed it. Can you expand a little bit on why Colorado did the geographic region parameters? What was their thinking behind that?
My recollection is that they have a very fractured market with you know, regions with very different carrier mixes. But I would have to research that some more on exactly why they thought that was necessary.
And my understanding to add is that I think Colorado has very different hospital costs depending on geography. I think their hospital costs and so they in those geographic areas claims are much higher. It's that and the fact that premiums were quite varied across the state depending on the rating area was part of why they were pursuing that, which is we don't have the level of disparity in Maryland that I think Colorado is looking at.
My conversations with Commissioner Conway, just at a very high level, is that there's also consideration given to sort of health equities, you know, costs and claims, you know, regions and outcomes. And that was one of the purposes of, you know, breaking into regions and supporting some regions with higher reinsurance than other regions. Additional thoughts and comments? If not, we will move on to, I think, the next slide. And, you know, Brad, you can sort of lead this discussion.
Yeah, thanks. Just one last thing. I mean, on the idea of, you know, having some sort of outcome based component, you know, any concrete ideas on how to actually do that, you know, are welcome. You know, I think I've heard the broad desire to do such a thing before, but I've not seen any other state doing this, and it's hard to conceptualize what exactly that would look like and what kind of quality metric we would use and how that would be incorporated to actually, you know, modify the payments. And so any ideas on how that would actually work, you know, are welcome. Please, you know, submit it afterwards via written comment. All right, so to move on to this slide, you know, the big question, you know, is should we keep our program at its current size? You know, is this the right size where we want it, or do we want to increase it? Is there still a need to go even larger? You know, Alaska is the one state that has a larger program. Or should we think about decreasing the size of the program? You know, we have achieved, you know, the cheapest bronze and gold premiums in the country. You know, we're 9% cheaper than the next cheapest state. You know, our program is double the average size of other state reinsurance programs. You know, should we be thinking about decreasing it? And then, you know, how do those answers differ if ARPA doesn't get extended to the end of 2025? And you know, I presented those ARPA numbers earlier because I think this is one of the big decision points. And I mean, I think there's no way for me to get around modeling things both ways. That ARPA is just so important. And so we don't know what the feds are going to do at the end of 2025. But you know, I think, you know, how does ARPA impact our answers here? And so, you know, welcome any thoughts on you know, what kind of you know, changes we should think about making in the ARPA versus our ARPA extended versus ARPA end scenarios.
And Brad, just for clarity, I think the slides that you presented had shown that the direct subsidies through ARPA had a greater impact than reinsurance. Is that what you're trying to say in that slide? And are we doing that modeling to see if we shifted from reinsurance to more direct subsidy that we would experience the state would experience that same benefit?
The direct subsidy was more impactful to the premiums for older individuals than our reinsurance program. I'm not necessarily saying that I think the state should do that. I mean, I think the difference is the funding. I mean, the reason why reinsurance is so attractive for states to pursue is the pass-through funding, which is really not available for premium tax subsidies. And that's the crux of the issue, that the feds will pay 2/3 to 100% of your reinsurance costs for you. And so for our first waiver period, we generated $2.1 billion in federal pass-through from $830 million in state assessment. I mean, we got $2.50 in pass-throughs for every dollar the state put up, and we're going to do better in the projection period. And that's just not possible with premium subsidies. And so that's the balancing act. I mean, a premium subsidy is more targeted and more effective, but it's funded by more of the state. You might get 5 or 10% back from the feds to the extent that you're helping improve morbidity, but you got to fund the full cost of that. So I mean, I think ultimately, we need to balance, and I mean, I think for over 400% FPL, it makes more sense to target via reinsurance than via subsidy. But for lower incomes, the subsidies are where it makes more sense.
And Brad, I'll just add to what you were saying that we'll discuss this more in our next meeting session, but we are also taking a look. There are 3 states that have leveraged Medicaid funding for their subsidy and cost sharing programs. And so they are able to get a federal match via Medicaid for subsidies for lower income folks, which kind of helps with that funding picture. And whether that makes sense for Maryland, that's something that Alyssa and her team are doing more of a deep dive into, because of course Medicaid funding and waivers are a complex topic, but there could possibly be an opportunity to get additional funding, not through the 1332 pass-through route, but through a Medicaid match route for the lower income subsidies.
So I think I saw Allison and then Rob.
Thank you. And to these questions, a couple of thoughts. One, Maryland has done such an admirable job in lowering premiums, and the fact that we are the lowest in the nation in some metal levels, and I think it was the 3rd lowest in silver, is really, really admirable. And, I think there's a lot of value in the state continuing to pursue that as an objective. One thing I thought was interesting on one of your earlier slides, and has been a concern of ours all along, is the cost growth of this program. One projection I looked at recently that from the exchange last summer suggested that the state funding could be depleted as low as 2025. I saw on your earlier slide, based on a change, I think in raising the attachment point by $500 for each year. And I think your model, I think it was slide 12, was also assuming maybe that the ARPA subsidies were continuing. I'm not sure, but ultimately the way I was reading that slide was that the program would be solvent sort of at its current size through the end of 2028 with those changes. Was I reading that slide correctly?
Yeah, the latest projections are that we're going to be solvent through the end of the next period. You know, we got better pass-through final numbers for 2023 than we originally expected, and it looks like 2022 reinsurance is going to come in a little lower. And yeah, we are assuming that the attachment point goes up, but yeah, the latest projections are bare, you know, solvent at the current level.
Okay, that's great to hear.
And
You
Allison,
know, I think
just to be crystal clear, I just, so as you're contextualizing, is that temporary reduction of the attachment point, which will come back, 100% of that was funded with $50 million that was targeted to go out of the reinsurance fund already.
Right.
200 million had been sent out. We were able to claw back 50 million of that, which is what's funding that. And, you know, with the pandemic, with the uncertainty initially around ARPA, what it allowed us to do was level and not have too much shock for that 44% that received no subsidies whatsoever. So, but that will, the intent has always been to bump that back up. And it was done in a way that all of it was coming out of money that wouldn't otherwise have been there. So I just want to make sure that people, you know, keep in mind that that temporary change did not come out of the true pool, the true dollars that were in the fund.
Thanks for that clarification. And thanks also for working with the governor for getting that additional money that otherwise would have been taken out of the program for other uses. So I appreciate that. And then to the question about decreasing or increasing the size of the program, I would maybe like to speak to that at the next meeting after we see what else you all are considering, to just give an overall sense of what you know, what's in the mix and where the focus should be. You know, we at Kaiser Permanente continue to support the reinsurance program, but would want to speak to its size in context with what else you all are considering.
That's fair enough. Thank you. Rob?
Thanks, Brad. Appreciate it. You know, I think you really hit the nail on the head in terms of what the crux of the issue. I recognize that. Apologize. We're sort of coloring outside of some of the core discussion topics here, but you know, as we consider any kind of an either or, if that's the direction that the conversation wants to go, that there's $375 million in federal funding that's coming into the state this year for this program. And so Joanna's points are interesting. I candidly did not know that there were some alternate funding sources for state subsidy programs, but I just want to be sure we're keeping that in mind. To the extent you're pulling $1 in state funding out of the reinsurance program, you're actually pulling $3 in federal funding out of the state, right? So you're pulling $4, not really $1 out of the state, if you will. So I think it's just important to keep in mind that in terms of any kind of an either or approach that we look at, we really do have to look at the leveraging of federal funds that could flow into the state. And that's a really important consideration from our perspective. That said, we are certainly supportive of considering other potential state support programs. The state subsidy program could be a great idea in order to provide additional support to lower income folks, particularly if those ARPA subsidies were to go away at the end of 2025. But we do think there needs to be consideration of an additional and an alternate funding source that could be increasing the size of the existing assessment, looking at other sources of funding. We're absolutely open to whatever that conversation is, but decreasing the size of the current program is concerning from our perspective, particularly significantly decreasing it, because we know what happens, right? We were there in 2017, 2018 we have that real world experience and we don't want to go back there. So from Care First perspective, we feel it is important to keep the program at its current size. That doesn't mean that we can't consider changing some of the parameters, right? So increasing the attachment point. I think as you look at healthcare costs rise over time, it probably does make sense, right, to look at increasing some of those parameters, you know, in tandem. Both the attachment point and the cap over time would be supportive of that. So thank you for the opportunity to provide some input.
Thanks, Rob.
Any other questions or comments? Ken?
Yeah, so one of the comment I have is that, you know, of all of these, you know, adjustments of parameters, we have to keep in mind, you know, how do we grow our enrollment, you know, of the unsubsidized and also those who need subsidies. So so finding the right mix of adjusting these parameters, whether you want to increase the attachment point and lower the coinsurance, or increase the cap, we have to find the right balance in order to really not increase the premiums or rates for consumers while balancing, you know, the cost of the reinsurance program so that it could be sustainable.
Thank you. I mean, that is a sensible point, right? Because the reinsurance program really has the most direct impact and benefit on the 44% of people that aren't receiving federal support. And the people who receive the federal support, that support is what goes into funding the reinsurance program, which kind of goes to Rob's point about where dollars in and dollars out. And if we look at who is uninsured, you know, on average across age groups, you've got, you know, about 2.5% of the uninsured are within that group that wouldn't be receiving subsidies from a, you know, their income standpoint. The vast majority of people who are uninsured are people who would either be, you know, Medicaid eligible or would be eligible for significant subsidies with private insurance. And that goes back to Ben's point around, well, that's not the whole economic picture. So you're right, it is a really important balancing test of what's the end result of any toggle, you know, that you're making, and who bears the consequence of that, and, you know, what's the substitute. So I think it's really important to get as much feedback as we can on some of these, you know, individual parameters and individual toggles. And, you know, in a minute, we'll go to some of the more concrete objective ones, because that's going to guide the modeling that Brad and Lewis and Ellis do, so that when we have, you know, our third, but certainly not our last stakeholder discussion, there can be discussion about, well, what is this all going to cost? And, you know, what are the appropriate sources of funding? Any other comments? Anybody who is not on the panel who wants to be heard? I don't see any other hands, and I don't see anybody in the chat room asking to be brought over. So unless there's more, Brad, do you want to start to walk through the last discussion slide?
Yes. So this slide was just meant to talk about the specific parameters. So even if we want to keep the program at its current size, which sounds like there's more people advocating for that than not, you know, there's a question of do we want to get to the same size a different way? Should we tweak our attachment points or tweak our parameters? And you know, the attachment point being as low as it is, you know, I know this has been a concern of mine personally since, you know, we first set this $20,000 attachment point back, you know, in 2018, and you know, it is impactful and you know, has made it a very meaningful program, but has also made it so, you know, reinsurance touches a very meaningful portion of the pool, and it's increasing every year, and we've never raise that 20,000 attachment point. As the commissioner went through, we temporarily lowered it, you know, to take advantage of $50 million in funding. But, you know, personally, I think that, you know, we should definitely consider raising an attachment point, and you know, we can keep the program in its current size by also raising the cap and getting to the same average amount of reinsurance, but not having it touch so many people. And I think that would be maybe a better design, and you know, long term, it's just going to keep getting worse. More and more people are going to be reaching $20,000. And you know, the co-insurance at 80% is the other thing that, you know, we are taking out more in claims than most other states are, and leaving less skin in the game for carriers. And to the extent that there is concerns about quality and outcomes, you know, if we have a lower co-insurance percentage and don't take as much out, and leave the carriers with more skin in the game through all levels of claims, you know, those are the considerations that I personally had. But I wanted to get feedback on these. You know, as you know, I personally, what do I think the attachment point should be other than $20,000? I don't have a firm number in mind. It's just, you know, I do think it is low, and we should think about raising it. All right, Rob, I saw your hand go up first.
Oh, thanks. You know, just I think I touched on it earlier, but what you just outlined makes a ton of sense to us, right? Looking at beginning with the attachment point. You know, again, we support keeping the program at its current size, but within the existing funding constraints, and particularly given the unknowns. In terms of the federal funding, understand that, you know, we're going to have to work within those, you know, those parameters. But if we want to keep the program at the current size, starting with the attachment point, looking at raising the cap, as you outlined, makes a lot of sense to us.
Thanks, Rob.
Delegate Collison, I think, was next.
Thank you, Commissioner. Brad, I know I got down your sense of the attachment point and the co-insurance. On the cap, can you tell me where your head was on the cap? I think I just heard Rob say you were looking at perhaps raising it. But I wasn't clear when you were describing your sentiments on these particular parameters. And I guess the other thing before you answer, I guess, you know, I want to go back to some of our previous discussion in saying, you know, these questions are all relevant to if everything stays the same, if the reinsurance stays, you know, as it is currently framed in our legislation. But I think part of what we're here for is to do what I know I heard the commissioner and Matt Celentano talk about, in looking at the broader picture of how do we make sure that we can, you know, maintain premiums, but or sustain lower premiums and make sure that folks are covered. So that being said, Brad, where were you on the cap?
Yeah, sorry, I think I was not very clear there. I mean, I'm basically viewing the cap as the balancing item. You know, if we raise the attachment point, then in order not to shrink the size of the program, we would raise the cap. And exactly how much would need to be solved for actuarially. And you know, there's limits to it. We couldn't raise our attachment point from 20,000 to 100,000. Probably wouldn't have enough room to balance that out with the cap. But we can certainly go from 20,000 to 30,000 and use the cap as the balancing item. And same thing on the co-insurance. You know, if we wanted to lower our co-insurance from 80 to 70, you would use the cap to offset that and balance it out. So, you know, I don't have a strict view of the cap, but using that as the toggle point to solve to where we need to get to.
That's really helpful. Thank you, Brad.
Yeah, no problem. Allison.
Thanks, Brad. A couple of thoughts. I would agree with what Rob and you have said about the attachment point. I think it could make sense to consider raising it. Inflation, unfortunately, has been a reality the past few years. I actually looked up before this call to see 20,000 in 2019 dollars is just over 24,000 in 2023 dollars. And I think that's a reality that we wish wasn't the case, but just wanted to provide that. In terms of cap or co-insurance, I would need to take that back, but in the comments, we'll submit in written comments if we have additional feedback to provide on those points.
Thanks, Allison. That's a great but sad point about how much inflation has been over just the past 3 years. Ben?
Somewhat the same point that Allison made. I think the only additional fact I would say is we should consider if we are thinking about increasing the attachment point of indexing it to some external index factor that would allow us to kind of continue the same level. Allison's right that the last period up to 2020 we had very low inflation, but since then significant overall inflation, although interestingly medical inflation has actually been a bit slower than overall general inflation, but that's probably not going to hold for too much longer. But I'd favor increasing the cap and indexing it so that it maintains some sort of continuum to otherwise overall medical or economy-wide expense. On the cap, I want to say that I really liked what the payers were, or I think Matt was suggesting, embed some quality or performance-based measures. I'm not sure how that would play into any sort of cap adjustment, but I think adding some accountability would be something we got to consider, although it does add complexity.
And I'll just add to that, Ben, that is on the strategic plan for the Maryland Health Benefit Exchange, is looking at how we take those carrier accountability reports and use that information for outcomes and tie it into the reinsurance. So it's on our strategic plan. And I think we are talking about engaging some actuaries to help us with that and look at that. But I agree, I'm with you 100%. That's why we put the carrier accountability reports in place when we started the program, is to really make sure that the millions of dollars that the state is paying for the reinsurance program are not only keeping premiums down, but that the outcomes and the care that's being given is improving as well.
Yeah. Just one observation is that, for people who don't look at healthcare costs day to day, hour to hour, $20,000 is a knee replacement, in Maryland today. 6.9% of the population infected, that's a dramatic impact. Both in terms of write-off on claims from payers, and in terms of what healthcare costs today, it's not a lot of money.
Other thoughts or comments, or anyone who is not on the Allison?
One quick question, Brad, I loved what you had on your slide about the attachment point about how much of the population it picks up at various levels. In terms of the cap, do you have a sense of now at our 250,000, it can't be that many members who reach that. Do you have a sense of that? I'm just curious.
I have those numbers, just not at my fingertips. I could get back to you after the meeting. But no, I mean, it's a pretty small percentage. And so, yeah, moving the cap is not going to have a very big impact on how many people are going to hit that cap. But yeah, I'll get that to you after this meeting.
Thanks.
And yeah, I mean, I'll just say, you know, in written feedback from everybody, I mean, if anybody has ideas of a higher, more appropriate attachment point, you know, $20,000 is appropriate back in 2019. What do we think a new level we should be looking at? Is it 30,000? Is it 40,000? You know, that kind of specific feedback would be appreciated. And you know, for all of these, if you have any numerical, you know, specific feedback, that the more specific, the more appreciated it would be. And you know, if you want to give me a range and say, you know, 25 to 35, you know, numbers are great for actuaries. So you know, the more specific feedback you can give, the better.
And sort of in the same vein, but on a different subject, as Brad was saying about getting specific feedback. I know Brad already said that if anyone has specific thoughts on a way of incorporating value into the reinsurance program, we'd appreciate any particular thoughts on that. In addition, you know, the closest comparison that I can think of is Medicaid programs. And I know many Medicaid programs, including the Maryland Medicaid program, has a process of incorporating some value-based payment aspects into MCO rates, either through withhold or a bonus. So any thoughts that participants have on whether that model is at all translatable to reinsurance or not would be valuable.
Any other thoughts or comments on this topic? We're doing well with time. So I know that I don't see any hands and I don't see anybody else who wants to comment. Our next agenda topic for today, and we've sort of touched on some of this already, just at very light levels, would be impact of other individual market reforms at the state and federal level. So Brad, do you want to kick that off? And then, you know, we sort of have open comment that's available. And you can probably take the slide down, Craig. We can put that back up at the end. But, you know, Brad, in terms of this agenda item, do you want to lead the discussion on other reforms at the state and federal level?
Yeah, I mean, the big we've already touched on, you know, the big one, which is ARPA and the need to bifurcate our plans and our recommendations. You know, ARPA right now is scheduled to last through the end of 2025. And you know, if and when it expires, it's going to have a significant impact on the reinsurance program. You know, we're going to get less pass-throughs. We're going to have a smaller market, and you know, we're going to have a bigger need because ARPA is not protecting people. And you know, beyond that, you know, we walk through the, you know, state young adult subsidy and how that interacts with ARPA and our current reinsurance program. And those were the only, you know, two things that I was really going to go through. I mean, there's also the easy enrollment program that you know, helps feed into it. And you know, that gives the opportunity for the mid-year enrollment period, and those members get to benefit from those other programs. So it's more of a complementary thing. You know, the easy enrollment, you know, gives them the access to either get those lower unsubsidized rates if they're paying full price, or to get those lower subsidized rates if they're eligible for you know, the state and federal subsidies. But yeah, I mean, I think that's really all I had on that topic.
There are probably some other things that we can go into. Michelle?
So just Kathleen, in answer to like, kind of thinking outside the box a little bit, right? One of the very large cost drivers, I believe, and I would hope that the carriers will correct me if I'm wrong, is drug costs. And I'm wondering if we've thought about, or if we should think about, is there anything that if, we want to segment any component, would there be anything we could do around particularly drug costs and the impact that might have on focusing on that as driver of reducing overall costs? And again, I'm just thinking outside the box.
You mean in terms of allocation with reinsurance or a subsidy?
Yeah, correct.
Matt?
I just want to say, Michelle, that's fascinating, and I want to explore that.
Rob?
Yeah, I would just ask how that would operationally be possible, because the reinsurance report that would be possible, I think, in the context of the edge server reports more broadly. And no, I don't think any of it even gets into member level detail on cost. It may be challenging. It's certainly an interesting concept to explore. But I would ask Joanna or others who may have better understanding of the details, how we could operationalize something specific to just one element of cost.
I think one of the things too that would be really helpful here is, this is a good opportunity for, carriers and for other stakeholders to throw out ideas, that they have had. So that, the working committee thinking about them, we can percolate on them and talk about them in more detail at the next meeting. But if there are, ideas and concepts like, that's a creative concept from Michelle. We've heard people talk about, how do we adjust reinsurance based on some outcome metric, and what's a fair metric, and who decides the metric, and who evaluates the, whether the metric has been achieved, et cetera. And that's the discussion that is important to have. And we've talked about, other components like, do you put money into support for deductibles? Is that a better use of funds in order to, improve to drive down the uninsured population in the areas where it exists, right, economically? So are there other thoughts and ideas about that we haven't mentioned that your creative minds are thinking about, Obviously, the undocumented population is an issue. We've had lots of conversations about that and sort of how do we move that element of it forward. But there may be other areas and thoughts that you've had about how we can improve this program or do things differently with our dollars. Allison?
Yeah, so 3 ideas I've had. One is looking at the undocumented issue, and is there an opportunity, always getting more covered lives in the marketplace allows, we hope, a better risk pool overall, and if that would help with some affordability challenges. To Ben's point, I would say we like the idea of some kind of a value-based care component. Medicaid has a program, a number of Medicaid programs across the country have some kind of a value-based purchasing program in place that could be a place to start. I don't know, I would have to look at how translatable that something like that would be. And then, yeah, just looking at some other market reforms such as subsidies and how we can right size these all together to make sure we're maximizing federal money and keeping premiums down. So those are the ideas that I've been throwing around.
Anybody who's participating who wants to be heard on ideas, creative thoughts that they want to throw out there, for deeper discussion in our next meeting, you can just put in the chat that you want to be brought over because you want to be heard. I see Stephanie Clapper who's raised her hand. So Craig, do you want to bring Miss Clapper over? Looks like you're doing that.
Yeah, she should be coming over.
She is.
Hi, thank you so much.
Welcome.
Thank you. I'm from Maryland Healthcare for All, and not so much a creative idea, but just asking that as all of this is considered, to really look at how these ideas will impact health equity. And for example, one thing that we really loved to see from the Young Adult Subsidy Program is that young adult Latino enrollment increased more than any other group in the marketplace. And so I just think that's an important part of the conversation for any of these ideas.
Thank you. I agree. I think we all agree. That's an incredibly important component of everything that we do.
Thank you.
Other questions, other comments? Anybody else who is in the attendees who wants to be brought over? Not seeing anybody. So unless so the public discussion piece, I think we've just had. So I don't know if there are any final thoughts or comments, and we would just talk a little bit about process from here and give you guys a little under an hour of your time back. So seeing no one and no other hands, our intent is from here is to invite you and anybody else to provide any additional written comments or thoughts, which we will then post. So if you want to send them to Craig, I don't really have a time deadline on them. I would suggest, within the next week or so. Our next meeting is May 25th. So if you want the comments to be read and digested and, something that we can reflect back on, having it next week, sometime, maybe the end of next week would be very helpful, but I'm not going to put false deadlines on, people getting their thoughts to us. But that would be your comments on the slides, any of the discussions we've had, any concrete ideas, any specifics, any market ideas that you think should be considered. And to Brad and Johanna's points, anything that the more detail, the better. So if you have had ideas and you've had the opportunity to model them, or your clients have had the opportunity to model them, giving us that information would be extremely helpful. If you know something specific, concrete, and accurate that another state is doing that you think is useful for us to consider here, please provide, that information as well. Then the goal of the next meeting is to follow up, answer any questions that came out of this one, to make sure that we've had a good discussion about the current reinsurance program, and then have a really good conversation about other market reforms at the state and federal level, and what that means, and ideas around what are we doing with subsidies versus what we're doing with reinsurance, and how they might interact and interface. And none of this conversation is concrete, right? I mean, it is a moving target because it's a whole balancing act. And we will be doing then, coming out of these two meetings, Johanna and Brad will be putting their heads together, really thinking about more concrete ideas that can be modeled. And then we will be sharing the results of that modeling. And then that will be our June meeting, is to talk in a much more granular fashion once we've been able to put some real numbers around some of these ideas. And there will be things in the alternative, because there will have to be things in the alternative. And then we'll see where we leave ourselves after that June meeting, as the working group begins to work towards its initial draft of a report, which we want to expose in August, probably late August, so that we can have at least 2 public stakeholder meetings to walk through that report in detail. And then that will give us time, of course, to do a second turn we have enough time in our proposed schedule that we'll be able to get that back out for comment again before it gets finalized by the agencies and then sent to the governor and to the General Assembly. So that's kind of the cadence of where we're going. But we're going to be nimble and we're going to be flexible. And if we need to meet more than we've proposed, then we will try to accommodate that. So any last comments or remarks from anybody, including any member of the working group? Okay, well, hearing none, you all have a very happy remainder of your Thursday. And I am giving you 48 minutes of your life back. So thank you.
Thank you.